Price.
Good morning, my lady. Please may we call Professor Sir Gregor Smith, who will affirm.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth and nothing but the truth.
As I said to your colleague, welcome back, Sir Gregor.
Thank you.
Professor Smith, could you give us your full name, please?
My name is Gregor Ian Smith.
Thank you for providing a witness statement for this module of the inquiry, which is dated the 21st of February of this year, INQ 304847783. I understand you're familiar with that statement and you have a copy of it in front of you, is that right?
I am familiar with it and I do have a copy.
Starting, please, with your professional background. You are a general practitioner, is that right?
My specialty in medicine is general practice, yes.
Can you have a specialty in general practice?
You can, yes. It is a general specialty, but it is nonetheless, it is a specialty.
I was only teasing.
Prior to taking up an advisory role to the Scottish Government, you were a medical director for primary care in NHS Lancashire, is that right? In Lanarkshire, apologies.
I was, yes. I was medical director for primary care in NHS Lanarkshire for 5 years.
And in 2012, you became a medical advisor in primary care to the Scottish Government.
I did, yes.
Is it right that you became Deputy Chief Medical Officer in 2015?
That is correct, yes.
You were the Interim Chief Medical Officer from April 2020.
From April the 6th, 2020, yes, I remember the date very well.
Until December 2020, when you became the Chief Medical Officer.
That's correct.
And that's a role you continue to hold.
Yes.
Turning, please, to the role of the CMO in the Scottish healthcare system response to the COVID-19 pandemic. As CMO, you lead the CMO Directorate, is that right?
That's right.
You describe your role and that of your team as independent clinical advisors to government. You also say that where a decision taken by Scottish ministers is likely to impact upon the health of members of the public, Scottish Government processes ensure that clinical views are sought at an early stage. In the context of the COVID-19 pandemic, did this mean that once you took up the role of interim CMO in April 2020, you regularly attended Scottish Government cabinet meetings?
So to deal with the different parts of your question, then yes, your interpretation is correct. And my experience of 12 years of working in Scottish Government is that there is early and frequent involvement of clinical advisors in the formulation of policy. The role of myself and my team is to be able to provide that independent advice to officials and to ministers when it's requested. And as part of the response to COVID-19, I gave regular updates by attending Cabinet each occasion.
And it's right that you also attended the Scottish Government Resilience Room?
That is correct, yes.
You have very helpfully exhibited to your statement a list of occasions on which you attended Scottish Government cabinet meetings. It appears from this that you attended on a weekly basis between April 2020 and April 2022, is that right?
I think that's accurate, yes.
You say you attended the majority of Scottish Government Resilience Room meetings. How often did those meetings take place?
The Resilience Room meetings took two forms. They took meetings primarily for officials or primarily for ministers supported by officials. During those meetings, my deputies tended to attend the officials' meetings and I attended the ministerial meetings. There was no regularised meeting schedule. Instead, the Resilience Room met when it was decided that it was necessary for it to meet.
Is it right that at cabinet meetings you provided verbal updates on the epidemiology of the pandemic?
That is correct, yes.
You describe your approach to these verbal updates at paragraph 10 of your statement. You aimed to explain and translate clinical and scientific advice to enable Scottish ministers to understand it and make decisions.
That's correct. The aim of these updates was to try to enable any decision-making which was to take place at that Cabinet to be in the context of what the latest epidemiology in Scotland was suggesting, and also to provide information or knowledge of recent breakthroughs or recent evidence that was coming to light in relation to COVID response, both within the UK but also internationally where that was possible as well.
You explain in your statement at paragraph 13 that ordinarily, when advising ministers, the CMO would base that advice on trusted sources of evidence, such as published peer-reviewed journals. In a novel situation, such as COVID-19, the CMO is forced instead to assess whether the evidence that there is of sufficient quality for the purposes of decision-making. Can you explain, please, how you go about this task and how you express the level of confidence in the available evidence to ministers?
So at this point, and for many months of the pandemic response, there wasn't an evidence base which told us how to go about responding to COVID-19. And so we were very reliant on data, information and scientific consensus or clinical consensus as to how to respond. We relied very heavily on inference from the response to similar types of disease where that was possible as well. And all the time in the advisory structures that were put in place across the UK and within Scotland, what we tried to do was to create a consensus approach where the centre ground of scientific opinion and held the greatest weight. And then from there we would try to judge and try to give a level of confidence that related to that evidence, which we kind of framed as either low, medium or high.
You refer in your statement at paragraph 17 to the Scientific Advisory Group for Emergencies, SAGE, and the New and Emerging Respiratory Virus Threats Advisory Group, NERVTAG, as being part of the critical function of how evidence is received and considered. How often did you attend SAGE meetings?
Yeah, in the early part of the pandemic, I tended to, well, the invites began to come for SAGE probably by about early February to Scotland, where we had observer status rather than member status at those meetings. That still enabled us to kind of gain the information and the knowledge that was being discussed at those meetings without perhaps fully contributing to some of the questions. But over subsequent weeks and months, that relationship changed so that we were able to participate much more fully in those structures. NERVTAG sat a little bit to the side. It was a group which was particularly had a particular expertise on it, and we received reports from NERVTAG in relation to the discussions with opinion from those groups as well.
You describe in your statement there being exceptionally good and professional relationships between the UK CMOs. In response to the COVID-19 pandemic, is it right that you met regularly with the CMOs for England, Wales and Northern Ireland?
I think the first thing I would want to do in answer to your question is to emphasise those exceptionally good professional relationships, and particularly the willingness to engage and share information between the CMOs was quite extraordinary, actually, and particularly in those early parts of the pandemic response. It wouldn't be uncommon for us to meet, if not on a daily basis, then every couple of days, and at the very least a couple of times a week. We met whenever it was necessary, at any point in the day it was necessary, often evening meetings, often very early in the morning meetings, and we stayed in touch very, very closely during that time.
there were also regular meetings between the CMOs and other senior clinicians and scientific advisors. Was this the Quint Senior Clinicians Group meeting that you're referring to in your statement?
It is. That was probably the most obvious of the other groups and most important of the other groups, which met on a regular basis, meeting generally, again, on a weekly basis at the early part of the pandemic. It was made up of senior clinicians from across the UK, the CMOs, the CNOs, the NHS England Medical Director, National Clinical Director in Scotland, but also very senior public health officials from across the country as well, where we would examine data that was becoming available or observational studies or evidence from other sources and see how to interpret that and what weight of evidence to apply to that.
How often did the senior clinicians group meetings take place?
At the early part, it was once or twice a week, depending on need, generally settling to once a week schedule. But as the pandemic response over the years began to make it less necessary, it still met, but less frequently, sometimes just once every couple of weeks or every month.
Could we have on screen, please, paragraph 15 of Professor Smith's statement? That is page 4 of INQ 304844783. 6 lines up from the bottom of the paragraph, you say this: the evidence presented at these meetings was discussed and carefully considered, and where relevant would be used to formulate advice for clinical, medical colleagues, Scottish Government policy officials and Scottish ministers. Who was presenting evidence at these meetings?
It would vary according to the meetings. It would sometimes come from different public health agencies. It would sometimes come from invited guests. There would be presentations from some of the observational studies which were taking place across the UK at that time, COSIN, ISARIC. As time went on, we would feedback from other observational studies such as Siren or Vivaldi. There would be data which was made available to us from international sources. It was a variety of people, either members of the group themselves or people who had been invited specially to come to present because of the work that they were leading on.
You discussed the thinking behind the establishment of the Scottish COVID-19 advisory group in your statement provided for Module 2A of the inquiry. Could we have paragraph 41 of that statement on screen, please? It's page 9. And at paragraph 41, you say this: as discussed in Module 1 DG Health and Social Care statement, SAGE was a useful source of evidence and scientific consensus from which the CMO could develop advice for the Scottish Government. But a drawback was that observers and Scottish ministers could not ask questions directly of SAGE participants. That was why the First Minister arranged for Dr. Calderwood, then CMO, to set up the Scottish COVID-19 Advisory Group. The Scottish COVID-19 Advisory Group was established before you took up the role of interim CMO in March 2020, is that right?
That's correct, yes.
Do you consider, and that document can come down now, thank you. Do you consider that the Scottish COVID-19 Advisory Group provided a greater opportunity for observers and Scottish ministers directly to question those presenting the scientific consensus?
So to answer firstly your question, I have no doubt it presented a much greater opportunity for people in Scotland to be able to directly question the scientific advisors. We held a number of deep dives into various topics run by members of the group that afforded our very enthusiastic ministers to be able to ask the questions that they were really keen to ask of the expertise in the room. And I think that the Scottish COVID Advisory Group was a really important and significant beneficial group in terms of the interpretation of the evidence as it applied to the Scottish healthcare system and population.
Your background being in general practice, how reliant were you on the analysis of the evidence done by the Scottish COVID-19 Advisory Group, SAGE and NervTag when it came to understanding the evolving nature of COVID-19?
Although my specialty background is general practice, I'd worked in government and been involved in public health for many, many years before that. So although general practice afforded me a very good clinical opportunity that I'm very proud of, my specialism had evolved over time. So I am sure, like every senior clinician who was involved in the COVID response, I benefited from the advice of expertise around about me, both to discuss different pieces of evidence and compare our interpretation of that, but also because of the innate expertise that they also brought to it.
Was the consensus within these three groups broadly the same when it came to the epidemiology of COVID-19?
The consensus was broadly the same, although there was different levels of discussion in the groups, and the way that particularly the Scottish Advisory Group was constructed meant that there was often very lively debate about the interpretation of some of the findings, and often quite challenging conversations in relation to that before a consensus was brought forward.
Can you think of an example of that?
Just off the top of my head, a fairly good example of that would be about the strategy in relation to how we begin to control the rates of COVID in the country. Some within the group advocated for a policy for as near to elimination as possible. Others in the group viewed that as being unachievable.
Is it right that health protection information was provided to you in Scotland initially initially to your predecessor by Health Protection Scotland, then from April 2020 by Public Health Scotland through the National Incident Management Team? Yeah,
the structure in Scotland at that point in time saw at the beginning of the pandemic Health Protection Scotland as being the lead public health agency for health protection. But during the early stages of the pandemic, a pre-planned move to a separate body, Public Health Scotland, occurred. The same people involved under a different name and under a different governance structure.
And the information that was provided, was that through the National Incident Management Team reporting to you? That
was the most important of the routes, was the National Incident Management Team, which was constructed of public health specialists from Public Health Scotland, but also with representation from each of the Scottish territorial health boards as well, plus augmented by analysts from various other agencies.
In terms of the limits on the role of the CMO and the CMO Directorate, is it right that the role was and is not one of operational decision-making?
That's correct.
The inquiry understands that the NHS in Scotland was put on an emergency footing on the 17th of March 2020. Is that right?
That's my understanding. That's the date.
And that was before you became interim CMO?
Yeah.
What impact, if any, did this have on the role of the CMO in the Scottish healthcare system response to the COVID-19 pandemic?
I'm not sure that it changed the role to any great extent, because the prime purpose of the role at that stage, before and after, was still to provide that independent clinical advice to officials and ministers. The remit of the emergency footing fell to ministers rather than to the CMO.
Did it have any impact on the status of the clinical guidance being issued by you to clinicians?
I don't think it had any impact on the status per se, other than perhaps to say that it became more prominent in the minds of people who were receiving it, perhaps.
Apologies.
I was going to expand on that just a little bit, because one of the important aspects of the Scottish healthcare system that differs quite significantly from the English healthcare system is the lack of the NHS England as a separate entity. In England, the situation would have arisen where if there was a once for the country approach, NHS England would have overseen that through their governance structures. That same governance structure didn't exist in Scotland under an NHS Scotland body. And in my view, that's an area which my preference would be to see developed further.
Sorry, I haven't followed that. Could you?
Yeah. So England has NHS England as a separate public entity, public body. There isn't an equivalent in Scotland. Instead, you have 22 health boards, 14 of which are territorial health boards. So if you want a once for Scotland approach, that is much more difficult because you don't have a national entity.
So you're recommending, so you would prefer...
My preference, and this is a
would
personal
be for
preference.
the independent entity?
Yeah,
Separate entity, sorry.
yeah.
You dealt with working hours in the statement you made for Module 2A of the inquiry. Could we have on screen, please, paragraph 28 of that statement, which is page 6? And here you say that after you took up office as interim CMO in April 2020, you reassessed the capacity of clinical advice available to the Scottish Government and identified that having more senior advisors would be beneficial. You deal there with working hours for your senior team, which were generally in the order of 12 to 16 hours each day, 7 days a week. The intensity of that work lasting throughout 2020 and beyond, with little noticeable reduction throughout the period covered by this module. Is it right that you increased the number of Deputy Chief Medical Officers from 1 to 3 over the summer of 2020?
Yeah, the volume of work was quite incredible at that point in time, and one of the first steps that I took was to enhance that senior clinical team, but also to make sure that we were making far better and closer use of the other senior clinicians who worked within government as well, so the Chief Nursing Officer and the National Clinical Director as well. And that working relationship became very close over the subsequent response to the pandemic. But critically, it was very evident that if we were going to service the volume of demands that we had from different parts of government to provide advice, we had to make sure that there was adequate clinical capacity there.
That document can come down now, thank you.
So the stenographer missed it. Did you say made greater use of the Chief Nursing Officer and the National Clinical Director?
The National Clinical Director. That's at that point in time was Professor Fiona McQueen and Professor Jason Leach.
What was the impact on your team of the workload that you described at paragraph 28?
So the first thing I would want to say is that although I've characterised this for my team here, I don't think my team was alone in working those type of hours in this response. And I saw similar levels of commitment, effort from other areas of government and indeed the healthcare service as well. It was a quite remarkable effort, but it did have an impact on us all, and we were tired, and it was stressful work, and there is no getting away from that. And there was very little respite from it. So 7 days a week, working those excessive hours certainly has its toll, particularly as leave was just not an option in those. I can't remember the first time I actually took leave as part of the response. It was tough, and it was tough not just for us, but for our loved ones and our friends as well.
I'd like to deal next with the Four Harms and the Four Harms group in Scotland. It's right, isn't it, that the Scottish Government published a framework document in April 2020 setting out the Scottish Government approach to decision-making during the pandemic? So if you can give your answer verbally.
Yes.
Thank you. In the four broad ways in which COVID-19 caused harm, they were identified in that framework, weren't they?
They were, yes.
Could we have the section dealing with the four harms on screen, please? It's page 8 of INQ 30369-689. Do I summarise the first harm correctly as being direct harm to people's health, which in this document was measured by reference to the number of hospitalisations, ICU admissions and deaths?
Harm number one was direct COVID-related harm, and there was a number of ways that we measured it, including those ways that you have outlined there. But we drew upon data sets which showed rising numbers of infection, and as time went by, we understood that that infection also had impacts on both particular parts of society, but also had longer-term sequelae as well.
And the second harm identified was the wider impact on Scottish health and social care services in Scotland. Is that right?
That's correct. We referred to these as the indirect health harms.
The last sentence in the second paragraph, just scrolling down a little, please, acknowledges the postponement of other types of care and treatment in the healthcare system. And then the third paragraph says this: despite the NHS remaining open for those who need it, we have seen significant reductions in people seeking help. This will impact on those most at risk. The health impacts brought about by greater inequalities may themselves be significant over years to come. We must adapt to ensure that our health and social care services can resume this wider care as soon as possible, and this forms part of our planning for the period ahead. Was there a recognition by the Scottish Government, even at this early stage in April 2020, that the pandemic was likely to exacerbate existing health inequalities?
There was that recognition, and this was something which worried me greatly at that time. And the decisions that were faced by the Scottish Government is that there were no easy or no risk-free routes to be taken out of this, and that almost any decisions that ministers were faced with at that point in time would lead to some level of harm somewhere in society. Some of those could have been more facing the direct COVID harms if we hadn't taken action, but by taking action it had then an impact on the indirect harms. There was no easy route, and it was one of the perhaps the most difficult decision-making processes of all the pandemic.
What was done in April 2020 to try to mitigate the indirect harm that was anticipated?
One of the things that I certainly tried to do in my role as CMO was to make sure that messaging to the public that the NHS remained open for people who needed it was as loud and evident as possible. And I spoke about it on several occasions during the daily lunchtime briefings that I gave with ministers. I was particularly concerned that as we began to receive data, that we saw a real fall-off in the early referrals for cancer or for possibility of cancer, that people were not presenting with chest pain and with heart attacks to hospital. And that illness hadn't gone away, it hadn't disappeared, but people were perhaps absorbing that. And I think there was a very delicate balance to be given in the messaging to the public, which really had to kind of deal with some of perhaps both people's altruistic sense of protecting the NHS, which was evident, but also some of the fears that they had about presenting to healthcare at that point in time as well. And that was an incredibly difficult thing to do, but messaging that it was really important that people with red flag symptoms of one sort or another, whether that be chest pain, whether that be suspicious symptoms of cancer, that people were seeking help for that. And through social media, through the lunchtime briefings, through any communication portals that I could use, I wanted to emphasise that people should, and it was important that should still present with that.
Just focusing on the potential exacerbation of existing health inequalities, specifically as opposed to indirect harm. What was done in April 2020 to try and mitigate that effect?
First of all, I think the most important thing was to recognise that there was an effect. and then from there work could be done to try to limit the damage that those inequalities could have. Some of that was about supporting people to be able to make the right decisions for them and for their families, particularly when they had symptoms of COVID, so that they were able to isolate, they weren't going to work, and they didn't suffer financial loss as a consequence of that. Some of that was about trying to make sure that information which was available to some of our communities was done in as open and as accessible a way as possible, using community leaders, particularly faith leaders, to try to get that message across where there was difficulty in doing that, and recognising that there were lots of channels for that really important aspect of communication that lay beyond just clinicians and government ministers by themselves.
Just before we leave this document, is it right that the third and fourth harms identified in this framework document were respectively the social and economic harm caused by COVID-19?
That's correct, yes.
Could we have on screen, please, paragraph 239 of Professor Smith's Module 3 statement? That's page 55. And at 239, you say this: throughout the pandemic, as part of the four harms process and the Scottish Government's framework for decision-making, CMOD considered how the advice, policies or guidance to which it contributed might impact upon groups such as disabled people, older people, people in at-risk groups, members of ethnic minority communities, people from disadvantaged socio-economic backgrounds, and all people with existing health inequalities. Is it right that the CMOD was a contributor to the development of the four harms process through the CMO and the DCMO?
That's correct, yes.
That document can come down now, thank you. Was the four harms group the primary forum for discussion of evidence relating to indirect health harms caused by COVID-19?
At a cross-government level, that was the primary group where we would examine that. And the aim of the Four Harms group was really to try to bring together evidence from different parts of government and to treat that in a balanced way, to look at overall the harms that the country was experiencing as a consequence of the COVID response. I think it was important that both the direct and the indirect harms to the population were harms 1 and 2 and had particular importance. But really, they had to be balanced in any kind of national response. They had to be balanced by the knowledge and to try to offset the risks of the social harms and the economic harms that the country faced as well. In my view, the Four Harms process was a very successful way of doing that, and it led not only to really quite rich discussion as to how we might approach different problems at different stages of the pandemic, to try to balance the risks associated with those four harms, but also brought the professional advisors in each of those areas much closer together within government, so that we could have separate discussions as well about evidence as it developed and a better understanding, for instance, for me, of the economic harms and the societal harms that were taking place as well, so that we weren't solely focused all the time on just a narrow remit.
Could we have on screen, please, INQ 30217-490? These are the minutes of the fourth meeting of the Scottish Government CMO Advisory Group on COVID-19, which took place on the 9th of April 2020. Was that 3 days after you took up the role?
It was, yeah.
At this meeting, a paper entitled Calibrating the Impacts of COVID-19 with the Impacts of its Control Measures, Informing Decision-Making on Non-Pharmaceutical Interventions, this was authored by Dr. Jerry McCartney, who was an inequalities expert and a consultant in public health at Public Health Scotland. That report was considered at this meeting. We can see from the minutes excuse me, that you had sent your apologies and Graham Ellis was deputising for you. Notwithstanding you not being at the meeting, I'd just like to ask you about the consideration which was given to health inequalities, which were likely to result from COVID-19 restrictions. Looking please to page 3, paragraph 4. There is a summary of what the paper was addressing here, and starting about 4 lines down, it says the government's interventions to flatten the curve have been important to reduce mortality, but the negative economic impact will have a marked negative impact on health and inequality. The paper included a number of recommendations for how to influence health and wider policy areas, taking the opportunity to address health inequalities that emerge from this. And the group's input was sought on the paper's recommendations. There is a summary, going 4 paragraphs down, the paragraph starting David. David questioned whether papers shared in the group were aimed at shaping policy or commissioning further research. Sheila and Richard noted that government is considering points raised in the paper and expressed that the paper should feed into broader thinking. There's a comment on language, speaking of balancing rather than trade-offs. And then in the paragraph below, Jim commented that while long-term issues are clearly incredibly important, there are urgent issues also to address. In the last week of full reporting, there were almost 800 care home outbreaks in England. It is important that we address the issues of today as well as tomorrow. It appears from this that the response to the paper was that the expected longer-term health inequalities raised in it would be factored into the broader thinking, but that this was not at this stage a priority. Was that the position?
One of the ways that we have dealt with this over the years in Scottish Government is to think about a 3 horizons approach to the way that we try to deal with complex problems like this. And I think Jim's summary at the end of that paragraph characterises this quite well. There were really important issues that were right up close that we needed to deal with, or they were going to cause significant harm. And we needed to deal with those. But that shouldn't stop us beginning work that could have an impact further down the road, and that speaks to perhaps Horizon 1 right up close, but Horizon 2 slightly further away. So that it doesn't mean that they are dealt with in sequence, but in parallel. I think is probably the way that I would try to kind of frame that, and that type of thinking about the recognition that there was going to be both health and societal harms as a consequence of some of this response that would still need to be addressed at some point, didn't mean that we should simply kick that down the road and deal with it at a later stage. Actually, the thinking needed to start at that point in time.
That document could come down now, thank you. Were you made aware that this paper had been brought to the meeting?
Not only made aware, but I remember reading the paper because Dr McCartney has contributed to many of my pieces of writing over the years and to my annual reports. And he is an author who I respect his writing.
Did there come a time when the Scottish Government was able to focus on the indirect health harm caused by COVID-19 and the health inequalities that might be caused or exacerbated by COVID-19 restrictions?
I think the focus on the indirect harms in particular, as I say, started with, first of all, the messaging about the NHS remaining open, but really in the recovery phase that people would recognise took place in the UK as the NHS began to kind of more fully reopen and services start to get back to I can't say normal because I don't think it was normal, but certainly to a greater range of services being available to people. All that was factored in all the way through there, and the planning was evident all along. But at those initial stages, it really did feel like all hands to the pump to deal with the COVID response.
Is it right that the First Minister established an expert group to consider the impact of COVID-19 on ethnic minorities in June 2020?
That's correct, yes.
and later the Racialised Inequalities in Health and Social Care in Scotland Steering Group.
That's correct.
My lady, you will hear more about those groups when Nick Finn from Public Health Scotland gives evidence. I'd like to turn, please, to the evolving understanding of COVID-19. Could we have on screen, please, paragraph 209 of Professor Smith's statement? This is the Module 2A statement. And the last sentence of this paragraph, you say this: much more often than not, there were no risk-free options, but decisions where less bad choices could be made. Can you give an example, please, of a healthcare system-related decision of which this was true?
The most obvious example that I would give in respect to that phrase would be the decision to pause screening. And I think that was taken in March 2020 by my predecessor, which was an incredibly difficult decision. But it was taken for reasons to try to free up staff and resources to be able to respond to the direct COVID harms. There certainly wasn't an easy choice. But I think it was the right choice at that time. But no one was unaware that it wasn't without risk.
Would you make that decision again?
Placed in the same position as my predecessor was, I would find it probably as difficult as she did to provide advice into that space. The evidence suggested that at that time that it was the right decision to make. I noticed in some of the papers at that point in time that she questioned particularly some of the screening programmes. I think that was the right thing to do. I think the right questions were asked about it. And given the information that my predecessor was given, I would probably have made the same decision.
By screening, do you mean testing?
No, I mean the national screening programmes looking for instance, breast cancer screening or cervical screening or...
Did the that document can come down now, thank you. Did the identification of the least bad option when it came to the Scottish healthcare system response to the pandemic involve a balancing of potentially competing considerations, as you recall it?
Yes.
What is your understanding of the precautionary principle?
So the precautionary principle was something which was applied very often during the response to the pandemic, and where there was doubt in relation to evidence or data in an area that would cause sufficient harm to be concerned about, people tended to err on the side of caution, and perhaps over-calibrate a response to that.
Did the process of identifying the least bad option involve any express consideration of the precautionary principle?
In the example I gave you, I don't think you could say that the precautionary principle was applied in that sense, because there was an analysis of data. And as I said, by pausing screening, it released staff who could be redeployed into the direct COVID response, but also, very importantly, lab resources and skills in relation to labs that allowed the scale-up of really important programmes such as testing in that area.
Could we have on screen, please, paragraph 32 of Professor Smith's Module 3 statement? That's page 8. You deal in this section of your statement with understanding of COVID-19 transmission routes. In paragraph 32, you identify some factors relevant to understanding transmission routes, including pathogen dynamics such as viral load, environmental factors, host-related factors, and wider factors such as the prevalence of the disease. Then further down the page at paragraph 34, you deal with why some routes of transmission were easier to measure than others. Can you explain, please, why it was easier to measure close-range droplet transmission than airborne transmission?
So at that point, we were very much dependent on observational studies of the way that people became infected, and droplet transmission at that stage was felt very strongly to be the predominant mechanism by which SARS-CoV-2 spread. There was, at the very, very early stages of the pandemic response, as we were first identifying cases internationally and then in the UK, a lot of reliance on the dynamics of similar infections to try to judge how SARS-CoV-2 might evolve and spread as well. In that sense, the very close genomic similarity to SARS-CoV-1, there was about an 80% similarity, meant that there was a heavy reliance on that and some other respiratory diseases to try to kind of infer what the most likely mechanisms of spread were in that case. Droplet spread is rather more easy to kind of quantify than aerosol spread, partly because it's so difficult to measure viral particles in any environment like that. But certainly the evidence from these observational studies, that these initial observational studies, certainly seem to suggest that droplet spread was the predominant spread. But I think importantly, it didn't rule out the fact that aerosol spread was still a possibility. And
if I can just stop you there, because we'll come on to the detail of that, but just in terms of the measuring of those, your position is it was easier to measure close-range droplet transmission than airborne when it came to trying to understand things?
Through the observational studies, yeah.
Okay. Paragraph 35, you say this: there was a need to balance the level of infection risk from a given transmission route with the frequency and likelihood of exposure to this in day-to-day activities. For example, aerosol transmission across a room may present a low risk from any single exposure, but the ability of one infectious person to expose multiple people at the same time means it could present a higher population level risk in some settings than for close direct contact with an infectious person. Could you give an example, please, of the kind of settings in which one infectious person could expose multiple people at the same time?
I think the best way to try to explain this would be to imagine a closed, poorly ventilated environment, and I'm going to pick a hospitality space of some sort. But if it's an enclosed space with poor ventilation, and there is even a minimal level of aerosol generation of virus, although the individual risk of a person is relatively low in that respect. If it's a crowded environment with lots of people there, cumulatively the population risk to that group is much, much greater. So closed, poorly ventilated, crowded environments posed a greater risk for the possibility of aerosol spread, even at those early stages. And we saw that with some of the studies and the first super spreader events that took place, I suspect.
Would hospitals meet that description?
Generally, I wouldn't have considered hospitals as being as part of that description, no, because of the improved ventilation and filtering in modern hospitals.
There were some hospitals in Scotland, weren't there, or there probably still are, where the structure of the building, the age of the building, might make ventilation quite difficult. Factoring that in, does your answer remain the same?
Again, I would say that it's less evident in hospitals because of the space and the less crowded atmosphere than the type of environments that I'm closing. It doesn't mean that it's impossible, but it's less likely than crowded indoor environments such as crowded hospitality settings.
At paragraph 36, you say that it was important to retain an open mind about routes of transmission as understanding evolved over the course of the pandemic. Then in the last sentence of the paragraph, you say this: it was also important to ensure that absence of evidence was not interpreted as evidence of absence, and that important transmission routes to which there were potential countermeasures were not ignored. Why is it so important that the absence of evidence is not interpreted as evidence of absence?
So from my perspective, again, it's the precautionary principle that you outlined beforehand. Was that you had to keep an open and not a closed mind to some of this. There was great uncertainty at the beginning as to exactly the range of different ways that COVID-19 and SARS-CoV-2 could spread. Much emphasis has been given on droplet spread, but of course at that stage we were also worried about fomite spread of the fecal spread and even through bodily fluids of other sorts as well. So it wasn't just about droplet versus aerosol, but actually these other mechanisms of spread were always part of that consideration as well. And until there was much more learning and evidence which was available from the specific virus itself, I think it was important that we kept that open mind to the possibilities. And as I say, even some of the early observational studies, particularly one that I recall from China, suggested that in a closed environment, there could be, however minimal, at least some contribution from aerosol spread as well, although it was thought to be much less significant than other routes.
Could we have on screen, please, INQ 30300-579? This is a message which was posted on Twitter by the World Health Organization on the 28th of March 2020, which says this: fact, COVID-19 is not airborne. And it goes on, the coronavirus is mainly transmitted through droplets generated when an infected person coughs, sneezes or speaks. And then in the box at the bottom, the fact of COVID-19 not being airborne is repeated again in that bright yellow box. Is this an example of absence of evidence being interpreted as evidence of absence?
I remember seeing this when it came out, and I felt that at that time it was perhaps unhelpful to state so unequivocally the way that this was framed, because even at that stage and through some of the advisory structures that we'd been discussing this, it was felt that as I say, no matter how small, that there was still the possibility of some aerosol spread at that time.
You thought it was unhelpful. Did you raise your views on the WHO statement with your HMO colleagues? Sorry, CMO colleagues.
I think we had discussion at various times around about the role of aerosol spread. I don't remember specifically raising concern about this particular message. Although I do remember concern raising about similar messages.
I'm sorry, I spoke over you. You had concern about similar messages.
Yeah, I remember similar messages that came out from WHO that I raised concern about, about perhaps WHO being less forthright about the possibility of aerosol than I thought they perhaps could have done.
In terms of the timing of those other messages that you raised concern about, this was March 2020. When were the other messages you had concern about?
I could only say midsummer 2020.
Okay. We'll come on to the July messaging. In terms of what you did about your view that this was unhelpful in March 2020, did you raise that view that it was unhelpful with anyone?
Other than discussion with internal colleagues, no.
Did you raise it with RHI?
Not specifically, no.
Could we have on screen, please, paragraph 262 of Professor Smith's M2A statement? That's page 65. Here you say this: it was established early that the likely principal route of transmission for COVID-19 was respiratory, although secondary routes including fecal-oral were not excluded. From early in the pandemic, 3 components have been considered potentially important for COVID-19: fomite, droplet and aerosol spread. However, the global scientific consensus on the relative importance of these different transmission routes and the potential role of other routes shifted as new evidence emerged, and evidence has been continually reviewed as new variants of SARS-CoV-2 have become established. Notwithstanding the WHO's messaging about airborne transmission, is it right, therefore, that aerosol spread was being considered as a potentially important transmission route from an early stage in the pandemic?
So what I would say is it was considered as a potential route of transmission. The relative importance of it compared to other routes was yet to be established.
And that was the case by the time you took up your role as interim CMO in April 2020, was it?
At that point in time, it was still unclear as to the relative roles of each of the transmission routes, although it was beginning to crystallise more clearly that there was less emphasis on the fecal-oral route, and the exact contribution from aerosol spread was still unclear, but not thought to be zero.
Going over the page, please, paragraph 265. You discuss in this paragraph the early inference which was drawn from studies of transmission routes for other respiratory viruses, in particular SARS-CoV-1. And 3 lines down, you say this: in retrospect, this provided mixed early indications. On the one hand, the airborne transmission capabilities of SARS-CoV-2 are similar to SARS-CoV-1. On the other, there are a number of important differences, such as in timelines of transmission and the much greater role of asymptomatic transmission seen with SARS-CoV-2. As for a respiratory virus, SARS-CoV-2 carried the potential for transmission via droplets and aerosols, direct physical contact, and indirect fomite-based physical contact. In your statement provided for Module 3 of the inquiry, you describe a comparison of genome sequences with other known human pathogens, which indicated that SARS-CoV-1 was the closest related human pathogen, with around 80% genomic similarity to SARS-CoV-2. With that in mind, was the initial assumption that there was at least the potential for SARS-CoV-2 to be transmitted by the airborne route?
Yes.
You go on in this paragraph to say this: existing evidence suggested that close contact with a person with acute respiratory infection carried more risk than a more physically distant contact, implying the importance of close-range droplet and, as now understood, short-range aerosol transmission. But there was pre-pandemic research into other acute respiratory infections, which was also drawn upon, which you refer to here. And going over the page, please, you say that showed the importance for transmission of exposure in public spaces, including public transport, shops, restaurants, parties, theatres and places of worship, suggesting an additional potential role for more distant, primarily aerosol-based transmission. Given that airborne transmission was harder to measure, and the importance of absence of evidence not being interpreted as evidence of absence, the potential for this route of transmission had to be taken seriously, didn't it?
Yes.
That can come down now, thank you. In terms of how the understanding of transmission evolved, could we have on screen, please, INQ 30375 This is a printout of some WhatsApp messages on the CMO WhatsApp group from July 2020. And I'd just like to look at the top message, please, which is from you, is that right?
That's right, yep.
And you say, I note the less than helpful equivocal statement from WHO this morning on airborne spread will no doubt become focus of attention until they produce something more definitive. There does not seem to be a reply to this message on this page, and the remainder of the messages relate to different matters. But this WHO statement was referred to by you in a Scottish Cabinet meeting on the 8th of July, the same day. Could we have the minutes of that meeting on screen, please? The reference is INQ 40785557. This was a meeting attended by a number of Cabinet members, including Jean Freeman. Going to page 2 of the document, please. We can see that you provided an oral coronavirus update at the meeting, is that right?
That's right, yep.
And paragraph 3 of the minutes deals with the numbers of cases and deaths.
Sorry, just before you go on, Ms Price, the minutes of the meeting held on the 30th of June, I thought you said the Scottish Cabinet meeting was on the same day as
If we can go back to the first page,
All right.
I think that's the first item on the agenda, which is to check
Oh, good, of course.
the
Thank you.
accuracy of the minutes.
Thank you.
Page 2, paragraph 3 deals with numbers of cases and deaths, but paragraph 4 deals with the WHO statement, which is said to have been made the previous day. And the summary of your update reads in this way. The previous day, a representative of the World Health Organization had made an equivocal statement regarding the possibility of airborne transmission of the SARS-CoV-2 virus, although further urgent research was required before a definitive position could be reached. The WHO's position remained that the virus was spread by droplet transmission, but a WHO official had now acknowledged some evidence to suggest that airborne transmission could not be ruled out in crowded, enclosed or poorly ventilated spaces. Pausing there, can you help with why you considered the statement from the WHO on airborne spread to be equivocal and less than helpful, that description from your WhatsApp message?
So first of all, the context is that the previous statement on this had been unequivocal in that there was not such a thing as airborne spread. And as I've already said, I felt that that was an unhelpful position to adopt at that stage. Moving to a more equivocal position was at least a positive step in that direction. But in my view, it wasn't sufficient to really enable the broader societal discussion about airborne spread and the response that might necessitate as well. Many of the nations around the world, including our own, placed a great store in the guidance which was produced by WHO, rightly so, given the expertise that they held. But I think that this was one area where there was more uncertainty about the role of aerosol spread than perhaps was generated in their guidance, and subsequently, as it became ever more clear that it at least had a contribution to make, as we began to kind of reopen society, if I can put it in those terms. One of the most important aspects of that reopening was the emphasis on good ventilation, and my view was that whilst the WHO continued down this track, it made it more difficult to get the necessary levels of investment in place and to convince everybody that actually investing in ventilation was something which was important.
Was that something that you wanted more investment to be?
But by that stage, and I'm not going to say that at that stage I was convinced, because there was still uncertainty, but certainly in my mind, it was one of the interventions which I thought was going to become much more important over time, was particularly in if you like, in opening up places for people to come together for meeting indoors, is that ventilation would have to play a big part in how we responded to that.
We'll come back to ventilation, but given the store that was placed in WHO statements and guidance, did you consider raising your concerns about the quality of the guidance and statements coming out of the WHO at this stage?
So not in a formal sense. So again, recognising the relationship that Scotland has with WHO, it's not a direct relationship. That becomes difficult. However, there was certainly discussion around about where WHO were likely to be heading with some of the guidance and the views on aerosol transmission at that stage.
Did you discuss your concerns about WHO statements and guidance with your CMO colleagues at this stage in July?
You've seen the WhatsApp conversation there, and that was never really kind of developed any further than that, as far as my recollection. Although my recollection is not complete at that stage.
Did you consider raising this with someone from RHI, given that those considering IPC measures were, it seems, placing a lot of store in what the WHO was saying?
So again, RHI, I didn't have a direct relationship with. RHI's relationship was with one of my senior clinical colleagues, the Chief Nursing Officer. And although there was certainly discussion between the senior clinicians in relation to this, I don't know how that was then taken on in terms of the direct discussion with RHI. I do remember frequently discussions both at Quint and in the CMO group about the need to ensure that the national UK IPC cell was continually reviewing the guidance in light of emerging evidence and approaches taken not just in this country but from around the world, and that was a point that was pressed home fairly frequently, and particularly and most importantly, I guess, when new variants of concern began to emerge.
Sorry, Professor Smith, you say that you didn't raise it with RHI because you didn't have a direct relationship with them. That was with the Chief Nursing Officer. But given your involvement with the Chief Nursing Officer, your discussions with your colleagues across the UK as CMOs, I'm not following the fact that you didn't have a direct relationship means that you couldn't raise it.
So it was raised through the channels that were available for me at that point in time. In terms of we would have a discussion about it and we would decide a consensus as to whether we should take that back to for instance, it was generally the UK IPC cell which would be looking at that more closely, rather than RHI in Scotland.
My lady, would that be an appropriate point for a 10-minute break?
We usually take 15 minutes, but...
Apologies, 15 minutes, my lady.
But what we'll do is we'll compromise, given it's 11:07, I shall return in, 11:25.
All right.
Ms. Price.
Thank you, my lady. Just picking up on the discussion we were just having about the WHO guidance and statements, and just to be clear, did you consider at this stage in July 2020 that the WHO was failing adequately to acknowledge the potential role of airborne transmission?
I think the context for this is that I thought that they were failing to acknowledge the possibility of aerosol transmission, although even at that stage my own view was that although I thought that it was possibly contributing, its contribution was very small.
Do you think you should have done more at that time in July 2020 to express your view, particularly to the groups who were dealing with IPC measure guidance?
Given that I thought the contribution was very small at that stage and the evidence that was available, no.
Looking at paragraph 5 of the minutes here, the summary of your oral update continues. if confirmed, and by that do we take it to mean if airborne transmission was confirmed, this would alter the measures required to protect against infection and could signal new risks compared with droplet transmission. Airborne or aerosol transmission was characterised by the much longer presence of the virus in the air when an infected person had been in a confined space. And then at 6, in discussion it was noted that this unconfirmed development, although potentially worrying, should in any case serve to underline the merits of using face coverings in public. The 4 chief medical officers of UK countries would continue to monitor closely the research in this area and would be alert to the implications of any changes in the formal position of the WHO. Was it your view at the time that if airborne transmission were confirmed as a route of transmission for COVID-19, that different measures would be required to protect against infection?
My view was that if it was confirmed as a significant contributor to transmission, and I think the important there is the clarification as to what extent it was a contributor to transmission overall. Then yes, I did believe that there would be a need to probably to emphasise some parts of the response in a way that was greater than we currently were doing, as I say, particularly ventilation.
Are the measures you refer to here, and you've just given the example of ventilation, but are you referring to IPC measures in healthcare settings?
All of that would have to be kept under continual review anyway, and it was kept under continual review. So I was confident that that would be a process that was ongoing. But as I say, I was particularly concerned that we may have to introduce additional measures such as a greater emphasis on ventilation, as I've already said.
The position you're putting forward here appears to be that a change in protection measures was not required until this development was confirmed. Is that right?
My view was that unless there was new evidence that showed that there was a significant level of transmission from aerosol spread, then yes, we didn't need to take additional measures, but we should stay alive to the prospect that may be the case at some future point.
Is this not the wrong way round, applying the precautionary principle? Shouldn't such measures be introduced in case airborne transmission is confirmed in the future, where there is some evidence of it acknowledged?
At the level of evidence, with the level of impact that was felt to be the case at that point in time, no, it would have been inappropriate to apply the precautionary principle.
This unconfirmed development was said by someone involved in the discussion at the meeting to underline the merits of using face coverings in public. Was there any discussion at this meeting of whether this development should prompt further analysis of the merits of altering protection measures in healthcare settings specifically?
I don't recall whether that was part of the discussion or not.
Well, there's no reference to it in the minutes. Do you think, therefore, that there was no discussion of it?
My view is that if it had been a significant part of the discussion, it would have been captured in the minutes.
Do you think this is something that should have been discussed at the time that this development in the evidence or acknowledgement of the development in the evidence was being discussed?
It was perhaps a discussion that wasn't for Cabinet at that point in time, but should advice have been brought forward to Cabinet specifically for that purpose, then I would imagine that it would have been a very appropriate thing for Cabinet to be involved in the discussion.
So I didn't follow that answer, Sir Gregor. Could you... It was perhaps a discussion that wasn't for Cabinet, but should advice have been brought forward to Cabinet specifically, I would imagine it would have been a very appropriate thing. Sorry, are you saying it should have been taken to Cabinet?
What I'm saying is that if a formal advice had been taken to Cabinet because it was felt to be so significant a development, and then I'm quite sure Cabinet would have discussed it in that respect. But at that, I think what the emphasis that I would want to put on this part here is that this was a very unclear moment as to the significance of the contribution of aerosol spread. At that point in time, it was still felt to be of a very low degree of transmission involved in any at that stage. And until there was greater evidence for that, then I can understand wholly why Cabinet wasn't discussing it.
You would have been the person to take it to Cabinet, would you? Use of face masks?
Probably what would have happened in those circumstances would, from the appropriate policy area, a submission would have been made to ministers in relation to advice that was given about face masks, and then the appropriate minister, if the decision lay beyond them, and it was a decision for Cabinet rather than for the minister themselves, then it would have been taken from there to Cabinet. As I've already outlined, I wasn't responsible for policy in relation particularly to face masks.
Can I go back to the point Ms Price was making about the use of the precautionary principle? And she established that you accepted the precautionary principle was important, that the absence of evidence doesn't mean... I can't get it right now. Getting everything wrong this morning, including my maths. The absence of evidence doesn't mean evidence of absence. Why are you looking for evidence of a significant contribution to transmission before you start considering other measures that might be sensible and in accordance with the precautionary principle?
Because at this point in time, the evidence suggested that the contribution was small, and therefore the gains which would be made by applying those additional measures would be so small that it would be a disproportionate response.
Well, shouldn't there have been some analysis of whether the response would have been disproportionate?
Those type of analysis were continually taken in relation to a number of things. I cannot comment on any analysis that was undertaken in relation to IPC specifically, but in terms of face masks for the general population, which I was more closely involved in providing advice around, I know that health and social care analysis teams in Scottish Government looked at the evidence for and against this fairly extensively, particularly contributions not only to the protection of those wearing them, but source control protection of others.
Sorry to interrupt, Ms Price.
Not at all, my lady. That document can come down now, thank you. It appears from the documents that SAGE provided advice on airborne transmission on the 9th of July 2020, the day after the Scottish Cabinet meeting that we've just looked at the minutes for. We can see that reproduced in a submission to Scottish ministers dated the 4th of August 2020, and that submission was copied to you. Could we have that on screen, please? It's INQ 30380-368. This submission related to the proposed expansion of mandatory face coverings to indoor public spaces. Going to page 2 and paragraph 8, please. The first paragraph of quoted text here, which is quoted text from SAGE, we can see that in the bottom right, says, in light of the WHO's recent communications on the risk of airborne spread, SAGE noted that its papers and guidance have consistently acknowledged that shorter range aerosol transmission is a risk, especially in poorly ventilated settings featuring a highly infectious person. The contribution of aerosol transmission relative to droplets and fomites remains unknown, but aerosol is unlikely to be the dominant transmission route. Research is underway on this subject and a UK research consortium has been formed. Did this represent the clinical consensus which was being presented to Scottish ministers at this point in time, August 2020?
So this represented the view that, as I said, I was more closely involved in formulation of policy in relation to face coverings for the public, the view that I felt was important in considering when ministers were making decisions about whether to introduce masking for the public.
My question is really, this is a view from SAGE. It is being put in a submission to Scottish ministers. Was this being put forward at this point in time as the clinical consensus for Scottish ministers to base their decisions upon?
Yes, it was.
Could we have on screen, please, INQ 30246-414? This is a June 2021 review of physical distancing in Scotland, produced by the Scottish Government. Looking at page 7, please. We see reference here towards the end of the second paragraph on this page to increasing evidence of airborne transmission over longer distances in some situations. Does this reflect your understanding of the picture in relation to transmission at that time, June 2021?
It does, yes.
Could we have on screen, please, INQ 30362893893? These are the minutes of a Scottish Cabinet meeting which took place on the 7th of December 2021. Again, you provided a verbal update for ministers. Going to page 3 of this document, please, paragraph 12. The update being provided related at this point to the Omicron variant. There is reference here to the suspected increased transmissibility of this variant. Going then to page 6, paragraph 23. Starting 3 lines down. In addition, the public needed to be warned about the increased risks associated with super-spreading events, largely as a result of airborne transmission, which must be understood to encompass almost any gatherings in crowded and/or confined spaces. As far as your assessment of the evidence went, is it right to say that you were of the view that airborne transmission, including aerosol transmission over longer distances, so not just close contact, was by this point confirmed as a route of transmission?
So by this point, yes, I would say that my very clear view was that the aerosol transmission was very real. Again, the extent to which it contributed was less clear, but that it was certainly contributing with this particular variant to some of the super spreading events that we were seeing.
How did you join the dots, so to speak, between your strengthening view on this and the consideration that was being given to, in particular, IPC measures by others?
So in terms of joining the dots, again, this goes back to the continual review process that was instituted by the IPC cell in terms of how they reviewed emerging evidence in relation to changes in circumstances. Now, those changes in circumstances might be new pieces of evidence that came out, or it might be the emergence of a new variant such as Omicron, which would mean a reassessment of the approach.
Could we have on screen, please, INQ 302030978? This is a statement from the WHO dated the 23rd of December 2021, dealing with how COVID-19 is transmitted. The first sentence at the first bullet point says this: current evidence suggests that the virus spreads mainly between people who are in close contact with each other, for example, at a conversational distance. And at the second bullet point, there is this: the virus can also spread in poorly ventilated and/or crowded indoor settings where people tend to spend longer periods of time. This is because aerosols can remain suspended in the air or travel farther than conversational distance. This is often called long-range aerosol or long-range airborne transmission. Was this the first official confirmation by the World Health Organization that COVID-19 is transmitted by the long-range airborne or long-range aerosol route, as far as you're aware?
I couldn't say with certainty that this was the first communication, but what I could say is that this was a communication that began to be much more consistent with my understanding of the situation.
How did this impact upon your assessment of the evidence relating to routes of transmission?
It reaffirmed my thoughts in relation to what I felt were the routes of transmission.
To what extent do you think the scientific consensus in the UK on routes of transmission was led by the official position of the WHO?
I think you can already see from some of the discussion that we've had so far today is that there was always an acknowledgement of aerosol transmission as a mechanism. As I say, the unclear aspect of that was to what extent it was able to contribute in the real world to transmission, and this was, I felt, a moment in time when the WHO position and the position of many experts in the UK began to kind of come much closer together.
That document can come down now, thank you. Given that some evidence of airborne transmission was acknowledged by the World Health Organization in July of 2020, do you think the scientific consensus in the UK was too slow to recognise its role?
I think that's a difficult question to answer, I have to say. And the reason I find it difficult to answer is because I think that there's evidence of part of the response long before that showed that the possibility of aerosol transmission was built into the response. So again, I take us back to a point in time in summer 2020 as we began to reopen society, and in light of the WHO position statement on that, some of the advice that was coming from the UK groups, some of the international evidence that was beginning to gather, a greater degree of strength. As society began to reopen, there really was an emphasis, you'll recall, on safer spaces being either outdoors or in well-ventilated spaces for good reason, and that was because of the possibility of aerosol spread. So I think even before that, there was certainly an acknowledgement. I couldn't say whether there was a broad consensus amongst every academic, but it was certainly strong enough for the advice that was being provided to ministers in terms of society reopening, is that we had to take notice of those safer type of spaces and emphasise those, particularly during times when the kind of prevailing levels, the higher levels of infection were affecting us.
Given the groups involved in providing advice, it was possible, wasn't it, for the Scottish COVID-19 advisory group to take a different view from SAGE, for example, and to provide different advice. Do you agree with that?
It was certainly possible. There were very few occasions where the advice differed significantly at all. I would struggle at this moment in time to be certain of an occasion such as that. However, I think where the Scottish advisory group perhaps placed a different emphasis on some of the advice that was coming out, and perhaps either a higher degree of confidence on it or labelled it as being more important in terms of the response that was taken. And again, I would suggest that cautious approach to reopening, more slowly perhaps than other parts of the UK as we did it, but with a much stronger emphasis on some of the environments that were felt to be at higher risk because of the lack of ventilation or the crowded nature of them. It became one of the features of advice that came not only, I would say, from the advisory group, but also from the National IMT as well.
Did you ever instruct your COVID-19 advisory group to look critically at what SAGE was saying in their advice?
Right from the beginning, the advisory group didn't need any instruction. They were very critical in every discussion that they had of all the advice and papers that they came across. One of the things that worked very well at the inception of the Scottish Advisory Group was the reciprocal agreement to share papers with SAGE and from SAGE, from Scottish authors of the advisory group to SAGE, and also access obviously to the SAGE papers as well. And what that did was that facilitated really often very direct discussion within the advisory group about the interpretation of some of the evidence.
Okay, but in answer to my question, is the answer no in terms of you providing direct instruction to that effect, i.e. could you look critically at what Sage is saying about transmission?
I would have provided direct instruction if it were required, but it was never required because it was inherent in the way that the group operated.
We've touched on the indirect health harms caused by COVID-19 and the exacerbation of health inequalities. I'd like to come now to the evolving understanding of disparities in outcomes for those infected with COVID-19. You deal with this at paragraph 67 of your Module 3 statement. To summarise your evidence here, is it right that by February 2020, there was evidence of increased risk of hospital admission for older adults, men, and those with certain underlying health conditions?
Yes, the picture that we were seeing emerging in other countries certainly suggested that there was at that stage there was a more severe impact on these type of groups.
In addition, you say that in the first wave, statistics highlighted high rates of hospitalisations among patients of Black and Asian ethnic minority groups compared to white ethnic groups. And you cite an ICNARC report dated the 10th of April 2020, which reported on statistics from England, Wales and Northern Ireland. Is it right, therefore, that this disparity in outcomes was something you were aware of from an early point in the pandemic?
It was something which I remember there being discussion on, both at the Scottish Advisory Group but also through the SAGE structures, and people were aware of it. People were also aware that there were many confounding factors which could be contributing to it and which needed to be fully sorted through and understood before there was a definitive position on it. But certainly at that early stage there was enough evidence to suggest that it really needed understood much more clearly.
I'd like to ask you about Public Health England's report, Beyond the Data, Understanding the Impact of COVID-19 on BAME Groups, dated June 2020.
Yep.
You deal with this at paragraph 69 of your Module 3 statement, if that helps you. This was an English report. To what extent were the recommendations applicable to England considered, adapted and implemented in Scotland?
Yeah, so there's many of the recommendations which applied equally to Scotland in the way that we had to respond, particularly around about the quality of the data that we would have, and you know the data collection systems in particular were areas which were looked at very, very quickly, particularly on hospital admissions, but we also acknowledged the importance of having to look at ethnicity data and how that was recorded in primary care systems as well. It wasn't recorded as well as it should be, and that was something which needed addressed. I recall that ministers also at that point in time set up the expert reference group to examine not only the impacts that pertain to the report, but actually some of the broader impacts that related to ethnicity across society as well. I think that was probably August 2020 that was set up in response to that as well. And subsequently it then reported in November with a series of recommendations which were taken forward as well.
Could I issue my usual request? Could you slow down, please?
I will do.
Thank you.
I'd like to come to a new topic, please, Professor Smith, and that is long COVID. Could we have on screen, please, INQ 30409591? This is the witness statement of Dr. Safia Qureshi from the Scottish Intercollegiate Guidelines Network. I just want to take you to one paragraph in it, which is paragraph 79, which is highlighted on the screen, which reads as follows. In July 2020, the Scottish Government COVID-19 Professional Advisory Group discussed reports of individuals with diverse long-term persisting symptoms after recovery from acute COVID-19 and supported a proposal for the clinical cell to develop national guidance on this topic. It noted that several teams in Scottish Government were working on different approaches to support people with ongoing symptoms. And then the paragraphs which follow deal with which those teams were. Do you recall discussion at the Scottish COVID-19 Professional Advisory Group of such reports in July 2020?
I don't think I was at that particular meeting, but I recall the reports that came out of that group and the proposals at that point in time to set up a much closer relationship with SIGN, an organisation in Scotland which is responsible for creating guidelines and a trusted source of information for clinicians in Scotland. And around that same time, there were increasing reports from people writing directly, but also media reports and social media reports, evidence from other places of longer term sequelae in relation to COVID. None of that should really surprise us because many viral diseases have that type of impact. But there seemed to be some particular nuances in the way that people were experiencing this that may be unique to COVID itself. And we needed to try to learn more about that. So the proposal to try to bring together all these strands of work in an integrated way, but also to explore with other UK nations whether they were doing any work in this, and to bring that all together eventually led to the joint project between NICE in England and SIGN and the Royal College of GPs to try to bring forward some formal guidance for clinicians on this.
You say this should not surprise us. Was any work done, anticipatory work done, before reports of long-term symptoms in Scotland?
I'm not aware of any anticipatory work that was done in this.
Are you aware of any done in the UK more widely?
Again, I'm not aware of any anticipatory work that was done in this that I could confidently refer to.
So July 2020, the summer of 2020, was that the first time that long COVID, as it came to be called, was raised with you or came to your attention?
With the degree of confidence that I have in my memory, that would sound about the right time.
What advice, if any, did you provide to the Scottish Government in July 2020 on long COVID?
So the main advice was to take forward this work to try to develop a package of, first of all, to understand what was meant by the term long COVID, because even at that stage there was the recognition that there may be the different people who had long-term symptoms were affected in different ways, and to try to understand that a little bit better. So to develop the evidence base for this, which might then inform some sort of more cohesive longer-term approach.
That document can come down now, thank you. Just a point of clarification on the long COVID timeline, if I may.
Yeah.
At paragraph 95 of your Module 3 statement, you refer to it becoming apparent by summer of 2021 that many patients have ongoing symptoms after recovery which persisted for longer than 3 months. You cite a Switzerland study from July 2021, and that's the same study that's cited in the CMO's technical report. By starting the chronology in your statement with the state of knowledge in summer 2021, you were not saying, were you, that this was the first time there were reports of long-term persisting symptoms?
Reports of persisting symptoms were starting to come through much earlier than that.
Because we know the first version of clinical guidance was in place by December 2020. That's right, isn't it? In terms of the progress which was made developing a clinical guideline after discussion of the issue in the summer of 2020, there was a Scottish paper dated the 2nd of September 2020. I won't go to it unless you need me to, but that addressed the need for a guideline. Is that right?
Could you go to the paper just to clarify?
Yes, it's INQ 3065757. So
this is from SIGN, yeah.
Yes, so I think you've seen this document before. It essentially sets out what is needed in September, 2nd of September. That document can come down now, thank you. You refer to the clinical guideline which was produced in December 2020 at paragraph 100 of your statement. Is it right that the Scottish Intercollegiate Guidelines Network ultimately collaborated with the National Institute for Clinical Excellence and the Royal College of General Practitioners over the guideline?
That's exactly how the guideline was produced. SIGN, as our national guideline organisation with relevance for clinicians in Scotland, and NICE as the equivalent organisation in England, worked with the Royal College of General Practitioners, particularly because of the impact on people presenting to general practice and the need for long-term follow-up to produce a guideline. And although what was produced was different in each country, the differences were really in the formatting and familiarity for clinicians, rather than being any kind of real difference in the content of them.
Can you help with why it took from July 2020 until December 2020 for a guideline to be produced?
I can't help you as to why there was that length of time. I could speculate, but that's not what I'm here for.
In May of 2021, you wrote to the medical directors of the NHS boards about implementation support following the publication of the clinical guideline in December 2020. Could we have that on screen, please? The reference is INQ 30480-831. You refer in the first paragraph, and this is dated the 5th of May 2021, to the guideline then in the... You refer in that first paragraph to the December guideline, which had been published. And then in the second paragraph, you say this: to support the implementation of the guidelines recommendations, the Scottish Government has produced additional targeted information for primary care teams, developed with input from key stakeholders, including specialty advisors to the Chief Medical Officer and senior medical advisors to the Scottish Government. The implementation support note provides primary care teams with practical information about implementing the SIGN guideline from a whole system perspective. Can you recall why implementation support was felt to be necessary?
Very, very often after significant guidelines, we look at actually whether additional support is needed in supporting clinical teams to actually implement the guidelines. In this case, because this was a new condition, it was felt that additional, for instance, one of the most important aspects is being able to identify people who may suffer from this in electronic records. So coding information that was specific to long COVID, for instance, becomes really important, particularly how that impacts on people. And this was intended to be a supportive tool, just to make sure that the actual guidance landed and was adopted as completely and consistently as possible.
Was there any particular incident or incidents which prompted the decision to provide this additional support?
No, I don't recall any.
Would it have been possible to provide implementation support earlier? And would it have been desirable to do so?
I'm not able to answer that question. I wasn't directly involved in the development of the implementation guidance, and it would be my view that this would be quite an undertaking in amongst all other activities that were ongoing at that time for a team to be able to develop the type of guidance that was then sent to general practice. Whether it could have been shortened or not, I guess it could have been shortened if additional resource, additional people were available to do that. But even then, that's not certain. I don't know.
In terms of the process, when did you become involved? Was it at the point of sending out this letter?
It was at communication.
Is it right, and that document can come down now, thank you. Is it right that from September 2021 there was a centrally funded long COVID service in Scotland?
There was.
And the funding consisted of a £10 million long COVID support fund, is that right?
To the best of my knowledge, that's my understanding.
Can you explain, please, how the provision of long COVID services in Scotland differed before and after the introduction of central funding?
Before the central funding was available, it's my understanding, based on conversations that I've had with the policy team who oversaw this clinical condition, but also some of the kind of operational clinical directors responsible in the boards, that much of the approach was more ad hoc and dependent on which health board patients resided in. There may be a different approach to the service, with some being more centralised specialist services and some being led within a kind of primary and community care setting. There were common features across different boards, common features such as rehabilitation support, such as in many kind of psychological support, but not an extant national specification in that sense prior to this, the funding being available. As it has been described to me, we then saw the funding becoming available, and there'd been a much more consistent approach to the way that these services would be designed and delivered within each of the boards, supported by that level of funding.
And were long COVID services improved after central funding was introduced?
I cannot give you an answer to that. And I can't give you an answer to that because I've never seen data which shows whether there were material improvements from people's perspective in relation to the care that they felt with this.
Were you involved at all in advising ministers on how long COVID services should be provided or how they should be funded?
I wasn't, no.
Could we have on screen, please, paragraph 104 of Professor Smith's Module 3 statement? Here you give your reflections on lessons to be learned from long COVID, and you say this: it is important to note for future pandemic preparedness that there may be longer-term consequences of an infection affecting a large percentage of the population, and that adequate surveillance mechanisms should be in place to capture the epidemiology of the condition accurately, to allow adequate planning of healthcare resources in the longer term. Was the potential for there to be longer-term consequences of infection with COVID-19 something which should have been recognised from the outset of the pandemic?
I think it's a common feature, as I've already said, of many viral infections, not every viral infection, but of many viral infections, that there are longer-term sequelae as a consequence of that. It's not unusual for respiratory viruses, although the most common that we see is flu. Even with flu, there's still some longer-term sequelae that people are aware of. With COVID-19, it was very unclear as to exactly what those long-term sequelae could be. Viruses are, for anyone who studies them, are fascinating organisms in the way that they impact on people, not just in the short term, but the way that their effects can sometimes persist in the body, either through long chronic infection or through the way that the body's immune response fails to turn itself back down afterwards. It was very unclear with COVID at first as to whether it was going to have those kind of effects, but it's not unreasonable to think that any virus infection could potentially have longer-term sequelae, and hence the reason for my paragraph 104. It's, for me, an important part of looking forward and making sure that we've got surveillance systems, not only to identify the pathogens, but actually the longer-term effects of those pathogens as well.
Was Scotland prepared to deal with long COVID?
The answer to that, in my view, has to be no. We weren't prepared at that early stage of the pandemic to deal with long COVID, partly because it was unknown to what extent long COVID would impact on the population. If you look at the range of impacts that long-term sequelae can have, from debilitating conditions like chronic fatigue syndrome through to incredibly complex and difficult sequelae such as Guillain-Barré syndrome, which can be life-threatening. There's such a huge spectrum of disease that you could be dealing with. It would have been very difficult to to prepare fully in any respect before knowing what you were dealing with.
Going back to Ms Price's question a little earlier, do you accept that Scotland should have recognised, and it may well be that all the countries of the UK should have recognised, the possibility of long-term sequelae at an earlier stage, given that it's a known consequence of many viruses?
Yeah, I mean, so I'm going to qualify this answer to you, my lady. And I'm going to qualify it by saying I think there was a recognition that it was a possibility, but we were unclear in what way that it would present, and then how to respond to that. So there was certainly an awareness that it was a very distinct possibility, but we weren't prepared to be able to deal with either the volume of long-term sequelae that we were seeing, or I think the type of long-term sequelae.
So having recognised as a possibility, was anything done other than recording the recognition?
It was really keeping alive to the fact and watching for the evidence arising.
Ms Price.
Thank you, my lady. Moving, please, to infection prevention and control. To what extent were the proposals of the UK-wide IPC cell considered by you and other UK CMOs before they became guidance?
I don't recall us ever authorising any of the guidance. I don't think that it was there was that type of relationship with IPC's cell. We were certainly aware of the cell. We received reports from the cell. Much of their work was channelled through the chief nursing officers, if you like, reporting structures rather than the CMOs, although we were certainly aware of the work. But certainly in Scotland, IPC fell under the remit of the chief nursing officer rather than the chief medical officer. And it was an area which, although I was involved in at times and gave views on, that I wasn't closely involved in.
Can I just follow that up? That seems to be the case throughout the UK. With no disrespect to the chief nursing officers or any of the people who are members of the cell, do you think in the future that is a sensible way to approach what is such an important aspect of guidance, infection prevention and control? Should you have other people basically either in charge of or on such a cell?
From my perspective, the expertise sits with these professions, and the specialism sits with these professions, and it would, whilst it may be useful to have external challenge in any group, and I don't single out the IPC as a group that would benefit from that. That is the root of the expertise.
But to ensure you have the proper measures for infection prevention and control, sometimes, as COVID proves, you have to have some expertise in some pretty complex scientific developments. And I just wonder whether that expertise could properly be analysed by the membership of the cell as it was during the COVID pandemic.
I think the IPC cell was fairly well equipped for that, because not only did they have subject matter expertise in IPC practice, but they had public health specialists, they had ventilation specialists. I believe that there was also input from the health and safety executive as well.
But do you not need expertise in understanding the nature of the virus that you're dealing with?
Which should have come both from the infection control specialists, and also the public health specialists on the group.
So going back to the airborne droplet debate, if you have expertise in how you can control a certain kind of virus that is droplet based, surely you need to be able to analyse whatever understanding there is, scientific understanding of whether it is droplet based. Haven't you got to have some kind of expertise to help the people on the cell? So you have somebody who analyses what kind of virus it is and the routes of transmission, and then you pass that to the specialist to say, right, how do you now protect against an airborne virus or a droplet-based virus that may be airborne as well?
So,
Isn't that what you need, that extra level of expertise?
so my understanding of what you have just described there,
Yep.
my lady, is exactly what happened in the
Oh, right.
in the IPC cell. Is that there was a multidisciplinary input, not just from IPC specialists themselves, but actually from public health experts in health protection, from ventilation experts, and from others who all contributed to the formulation of the guidance.
Thank you.
Could we have on screen, please, paragraph 145 of Professor Smith's Module 3 statement? In this paragraph, you set out some considerations for COVID-19 IPC guidance. And the first of these is emerging evidence on transmission risks. We spent some time earlier this morning on the developing understanding of transmission routes, and this follows on in some ways from Her Ladyship's questions to you just now. But in circumstances where there was some evidence of airborne transmission by July 2020, should the IPC guidance not have proceeded on the basis that there was a need to guard against the risk of airborne transmission from that point?
I think that when IPC guidance was formulated, it was formulated on the basis of the best evidence that they had available to them just now. I cannot comment what evidence that they considered at that time because I wasn't involved in any of the discussions, I'm afraid, and whether they considered the possibility of airborne and how they considered that. I think the point that you make about the possibility of airborne spread at that point in time, certainly it was recognised that there were certain procedures or points in time where that type of spread was much more likely, and the IPC guidance that was formulated at that point in time tried to respond to that.
The second consideration for COVID-19 IPC guidance, which you list in this paragraph, is international recommendations regarding best practice for IPC, which you say built on the established evidence base for IPC practices derived from the WHO. So are you saying here that there was reliance placed on what the WHO was saying on IPC guidance specifically?
So that was one of many sources that I understand that the IPC practices were derived from, but I don't think that it was the sole source. My understanding from the reading that I've done in this area and from the conversations that I recall from that stage was that not only were they taking advice from international organisations like WHO, European organisations like ECDC in terms of transmission, but also that they were looking at some of the UK, the broader UK groups who were reporting as well. And I think subsequently there was a subgroup of SAGE which was set up, which provided advice into the cell as well.
The last consideration on this page is ensuring that guidance was consistent with established IPC practice and easily understood by staff and implementable in all, just going over, oh, it is there, and implementable in all health and care settings. By implementable, are you referring to the practical feasibility of implementing IPC measures?
Yes.
To take the example of ventilation, I've already raised with you the issue of the design of older hospitals, and that might be a factor. Might that be a factor which was considered when deciding on ventilation IPC measures, i.e. the feasibility of introducing ventilation measures in an old hospital?
So I can't speculate whether that was one of the factors that they considered or not, but other factors such as the feasibility of being able to adopt any approach over long periods of time. So, for instance, wearing particular types of PPE over extended periods and how people would respond to that. The feasibility of even either availability or safe checking of the use of certain types of PPE. All of these may have been things which factor into that, but I have to say that some of this is speculative because I wasn't involved in the discussions.
Taking an example, could we have on screen, please, INQ 30492-302? This is an email chain, and if we can just start with page 1, please. You can see this is an email chain from January 2020. So at this point in time, you were Deputy Chief Medical Officer as opposed to Interim Chief Medical Officer. Going, please, towards the bottom of page 3, which gives the context for the exchange on page 1. And right towards, there we are, right towards the bottom, there's an email from Jim McMenamin, a consultant epidemiologist from Health Protection Scotland, to you on the 22nd of January 2020. It's copied to Dr. Ritchie, among others. And going over the page, please, well, further down if we're scrolling, the third paragraph on this page, there is this. In our PHE-led IMT discussion, we have been discussing the IPC support for general practice in the event of a symptomatic returning traveller presenting to general practice and then appearing in the consulting room and only then being recognised as a suspect patient who meets the clinical and epidemiological case definition. Then, if we can zoom out, the shared view of all 4 administrations on how to manage the situation is set out with those bullet points. And in short, to summarise, and bearing in mind this was at a very early stage in January 2020, the management was to involve the practitioner leaving the room, closing the door and isolating the patient until an ambulance could transfer the patient to hospital. Is that a fair summary?
Yes, that's exactly what the chain says. Yep.
Then about halfway down the page, there is identification of the issue you were being asked for your view on, which is reflecting the rurality challenge in Scotland. We have suggested that there is a risk that patients could need to be isolated for many hours, and thus there could be clinical circumstances where a practitioner may feel that they wish to attend their deteriorating patient. In this circumstance, we propose to offer a pragmatic infection prevention and control advice, which would use gloves and aprons and surgical fluid-resistant face masks. If we go back to page 3, please, of this document, we can see your reply in the middle of the page there. And you say, thanks for this, Jim. I think you know that I'm a pragmatist and I can foresee situations where clinicians will feel compelled to check on patients who have been isolated if there are lengthy waits for sought ambulance. So being able to offer some protection here is desirable. Can I ask first whether there are any other options that have been considered, and if so, on what grounds were these discounted? When you asked about other options, did you mean PPE options other than fluid-resistant surgical masks?
So I meant all options, as in whether there were either other ways of dealing with this in terms of protection that could be provided or other options in managing the patients, practical options in managing the patients in those circumstances. Remembering that this was a contingency that was being thought through here.
Your email is then directed to Dr. Ritchie, who responds the same day on page 1 of this document. And she says this: re your question about options considered, the option for FFP3 respirators is not one that can be easily and quickly implemented in general practice nor effectively sustained, specifically given the need for fit testing. To place this exchange in context, it's right, isn't it, that COVID-19 had been designated as a high consequence infectious disease earlier that month on the 13th of January. Would you agree that the consequence of that was that respiratory protective equipment was required for healthcare workers treating infected patients?
So in those circumstances, that would have been very much the desirable approach to this. And the context for this discussion is probably the most important one.
I understand that the context for what you were being asked for your view on is nuanced.
Yeah.
But that was the position in terms of the guidance at the
Yes.
time, or the requirement. What Dr. Ritchie was saying in this email was that FFP3 respirators, as an alternative to fluid-resistant surgical masks, could not easily and quickly be implemented in general practice, specifically because of the need for fit testing. It was in the context of GPs in Scotland in rural areas, and that it is quite a specific situation. But after you inquired about other options, you were told that this eventuality was discounted because it couldn't be implemented. Is this an example of a specific IPC issue on which there was not consensus being escalated to DCMO level for a view on the correct way to proceed?
So I think this is perhaps an example of, again, because of my links back to general practice, of understanding the nature of general practice and where general practitioners prior to the pandemic were responsible for providing their own protective equipment within the practice. So my knowledge of that enabled me to know that many practices would have very little or no protection, and certainly very little knowledge of how to use some of the more advanced types of protection, such as FFP3 masks. Fit testing in general practice is not something which has been undertaken in the UK, and I suspect that in this occasion, this was something which they came to me specifically for advice on because of my links back to general practice.
Is it also an example of an occasion on which the difficulty of implementation as a consideration has overridden the other COVID-19 IPC guidance considerations which you identify in your statement? So
this is, as I say, the context is really important here. This is about contingency. This is about making sure that some protection is better than no protection, and ensuring that at least there is something at this stage which is being done to try to offer people protection in very difficult circumstances.
I understand that in terms of the rationale, but just in terms of the decision that's been made, it appears that the ideal would be for them to have FFP3 respirators in the context and in the moment in time that this is. And the reason that couldn't happen was because of the impossibility of implementation. So am I right in saying that this is an example of a time where the impossibility or the practicability has overridden the other considerations?
So just to be clear, the ideal situation is for these patients not to be anywhere near general practice at all. The ideal situation is to make sure that the full HCID processes can be deployed when assessing a patient within an environment that's appropriate for that level of concern in a disease. This was a contingency in the event that someone should literally pitch up in general practice, waiting to be seen, and there may be a suspicion that this could be the COVID that was causing it. I'm not aware that it ever happened at this stage of the pandemic, but this is about ensuring that all eventualities have been covered, just to make sure.
I appreciate this may be another example of the least bad option, but the IPC decision is being made on the basis that
it's pragmatic.
Another option cannot be implemented. Would you agree?
In these circumstances, yes, I agree that is the case.
Just going further up the page, please. Your response was, thanks, Lisa, so I think we have a consensus, and I'm content to support the approach that's been outlined. So in the circumstances, were you content that this was the right decision?
I was content that it was the least bad option.
That document can come down now, thank you. As the evidence about COVID-19 transmission developed, do you recall the difficulty of implementation being a barrier to changes to the IPC guidance when other considerations weighed in favour of measures which might have afforded greater protection to healthcare workers?
As the response progressed, particularly as we began to develop greater knowledge of the virus and stronger supply chains, I don't remember that the implementation of the guidance, or I certainly wasn't aware that the implementation of the guidance became a significant problem. But that perhaps is best a question that's best directed at some of the operational directors who were responsible for implementing the guidance.
I'd like to ask you, please, about another COVID-19 IPC guidance consideration. Could we have on screen, please, INQ 30117-069? This is an email from Jill Vickerman, the Scottish National Director of the BMA. It's dated the 29th of April 2020. It is sent to the DG HSC, but is copied to you. It attaches a letter from the BMA dated the 28th of April 2020. I don't intend to go to that letter in the interest of time, but I understand you've had an opportunity to see that letter recently. That document can come down now. Thank you. The letter stressed the need for risk assessment of healthcare workers, given their personal characteristics might impact upon the risk they face at work. It raised 2 points in relation to ethnicity. The first was the disproportionate number of deaths among BAME healthcare workers, as well as the disproportionate number of BAME patients admitted to ICU. The second was the result of a BMA survey which found that almost double the proportion of BAME doctors felt pressurised to work in settings where aerosol generating procedures were being carried out with inadequate PPE. Was the increased risk for ethnic minority healthcare workers a consideration which was taken into account when decisions were being made about COVID-19 IPC guidance?
So the first part of your question, I think, would be better directed at people who are involved in the direct formulation of the guidance, because they would be able to give you an informed answer on that. What I can say to you is that it was a consideration as we received the guidance and interpreted the guidance for use in Scotland. For instance, we were aware of additional staff concerns in some areas that eventually led us to creating some additional flexibility in what PPE was worn, particularly when using AGP procedures in non-COVID areas. So if we understand the hierarchy of controls approach to IPC that has a multi-layered approach to how you begin to reduce the risk that's associated with infection. One of the last component of that is actually the personal equipment that people wear in relation to that, and there's many stages before that. But in the non-COVID pathways that had been set up, in terms of the advice that was given for what PPE could be worn, we in Scotland we adopted an approach that tended to strengthen that and give a little bit of flexibility. It became particularly evident as concerns were raised about what PPE should be worn in response to cardiac arrest. And again, my view in terms of my input to that area, and I know it was shared by other senior clinicians, was that finding a pragmatic approach that allowed a greater degree of local risk assessment and deployment of PPE for the circumstances was something which was important.
Others may be better placed to assist the Chair on the detail of the work which was done on individual risk assessments for healthcare workers in Scotland. But having been made aware of the increased risk linked to ethnicity, as well in that letter as age, sex and comorbidities by the BMA. Did you ask for anything to be done to ensure that COVID-19 IPC guidelines could be adapted to account for the vulnerabilities of these workers?
I recall raising it at one of the Quint meetings that we referred to beforehand as to whether this was something which needed deeper exploration by IPC authorities across the country. I think there was an action from that meeting, if I recall, that PHE would look at the some of the detail of that and then report back.
I'd like to turn, please, to the impact of a lack of complete consensus when it came to COVID-19 IPC guidance. At paragraph 146 and 147 of your statement, you acknowledge that despite strong relationships between relevant organisations across the UK, broad consistency of approach across the four nations, and collaboration and cooperation of external stakeholders, there never was complete consensus across all professional groups. Is that right?
That's correct.
I'd like to explore, please, the impact of this lack of complete consensus. Could we have on screen, please, INQ 304781114? This is the statement to the inquiry of Professor Colin Mackay, provided on behalf of the Glasgow Royal Infirmary. At paragraph 127 here, Professor Mackay says this: one of the issues which caused greatest staff anxiety was the management of cardiopulmonary resuscitation. In the event of cardiac arrest, HPS guidance was to use RPE for endotracheal intubation, as this was considered an AGP, but not for chest compression. This would allow immediate resuscitation to commence while full PPE was donned. This pragmatic guidance caused anxiety for staff, who felt that all aspects of CPR posed a significant risk to staff, and the situation was further inflamed by position statements produced by Royal Colleges and others, stating that chest compressions were also aerosol generating. The circulation of conflicting guidance by colleges and other organisations proved unhelpful and caused unnecessary anxiety for staff across the NHS GGC. The leadership team were clear on the necessity to adhere to statutory guidance rather than ad hoc position statements from other organisations, however well-meaning. At the time, were you aware of the lack of consensus on which aspects of CPR were classified as AGPs?
Yes, I was.
Were you aware of the difficulty that this was causing on the ground? At least it appears in this hospital.
Yes, very, very, very much so. And I was aware that there was a very live discussion, not only on the ground, but actually with many of our, in the regular discussions that we had with the medical Royal Colleges. They expressed their concerns over some of the conflicting advice in this space as well.
What was your view at the time on whether chest compression should be categorised as an AGP?
My view at that time was that I had no reason to dispute the evidence or the approach that was being taken by the IPC cell. They had considered it very carefully, and the evidence that they presented around about chest compressions seemed reasonable.
That document can come down now, thank you. Is it right that on the 20th of May 2020, a joint statement was issued by you, the Chief Nursing Officer and the National Clinical Director dealing with PPE and aerosol generating procedures?
Yes.
Could we have that statement on screen, please? It's INQ 304774445. We can see there that joint statement heading. Going to page 2 of this statement. The third paragraph on this page says, having reviewed the available evidence, NervTag concluded that it does not consider that the evidence supports chest compressions or defibrillation being procedures that are associated with a significantly increased risk of transmission of acute respiratory infections. It goes on. NervTag also states that whilst it is biologically plausible that chest compressions could generate an aerosol, this is only in the same way that an exhalation breath would do. An expiration breath, much like a cough, is not currently recognised as a high-risk event or an AGP. In addition, NervTag states that defibrillation is not likely to cause any significant breath exhalation. Based on this evidence review and NervTag's findings, UK IPC guidance will not add chest compressions or defibrillation to the list of AGPs. Underneath, however, we are in unprecedented times, and it is paramount that frontline healthcare professionals are supported to find a pragmatic solution to ensure their safety and that of their patients. NervTag recognises that the evidence base is extremely weak and heavily confounded by an inability to separate out the specific procedures performed as part of CPR, i.e. chest compressions, defibrillation, manual ventilation and intubation, airway management. Therefore, CPR within a hospital setting should be considered as a continuum, which is likely to include an AGP as part of airway management. In this case, the precautionary principle should apply, and the healthcare professional should be supported by their organisation to make a professional judgment about whether to apply airborne precautions, which would include FFP3 face masks, long-sleeved gown, gloves and eye face protection. NHS boards must ensure that this PPE is available for these frontline staff. Can you explain, please, why you and your colleagues took this position and issued this joint statement?
I think the key statement for me, particularly in that last paragraph, is the idea that CPR within that hospital setting is a continuum of activity. It's not just about a team arriving and starting manual chest compressions, because within a hospital setting it's inevitable that that will progress to other forms of intervention as well. And therefore, recognising that that is a continuum right from the beginning, it's important and pragmatic to make sure that people feel fully supported in how they approach this. And by writing this letter, myself and the other clinicians involved wanted, first of all, to show that we understood that there was uncertainty in this area, to recognise that, and as we state in the letter, in this case, to apply that precautionary principle given that continuum and give local flexibility for teams to be able to adopt the PPE that they felt was appropriate in those circumstances.
Was this statement well received by those on the ground, as far as you're aware?
I am actually not aware. There was some feedback from the college, from the Medical Royal Colleges, who were grateful for this clarification of the position. I don't know how it landed on the ground.
Professor Mackay, in his statement that we've just looked at, makes no mention of this statement, in fact saying that they were telling staff they must follow the IPC guidance. What was done to ensure that NHS health boards had got this message?
It was spoken about, so first of all it was communicated to the executive clinical directors within each health boards. It was communicated with the Medical Royal Colleges and in updates to them. It was spoken about at meetings with the executive clinical directors as well. So these are all points in time when these messages are able to be conveyed.
Was this position that healthcare workers could decide that they wished to wear PPE which protected against airborne transmission in this context, so CPR, maintained in Scotland, or did it change?
It was maintained.
That document can come down now, thank you. Turning please to IPC measures for preventing nosocomial spread to patients. The inquiry has heard that a COVID-19 nosocomial review group was set up in Scotland, meeting for the first time on the 7th of May 2020. Is that right?
I'm aware of the group, but I wasn't a member of the group.
The evidence that the inquiry's heard is that although you weren't a member of the group reported to you, as it did the chief nursing officer. Is that right?
It's not, no. It reported through the chief nursing officer, but it also had, what it did do was it provided input to the advisory groups, the CMO advisory group, but the group itself didn't report to me.
Does it follow that you did not attend the meetings of that group?
I wasn't a member of the group.
Were there any issues reported to you, even indirectly, by the nosocomial review group, which led to you providing advice to Scottish ministers?
I don't recall any specific instances when that was the case. That would have been unusual for me to provide direct advice to Scottish ministers on any elements of IPC as it lay out with the scope of my directorate.
Could we have on screen, please, INQ 30203-933? This is the UK CMO's technical report on the COVID-19 pandemic in the UK. Going to page 363, please. I should say it's dated the 1st of December 2022. The second paragraph down summarised the findings following computational modelling done to assess the effectiveness of IPC interventions in England during the first wave of the pandemic. That modelling identified that the most effective interventions for the prevention of nosocomial COVID-19 infections in patients were decreasing occupancy, increasing spacing between beds, and testing patients on admission. And the study referred to here was published, we find from the footnote, in 2021. Were you aware of the results of the modelling done in England during the period relevant to this module, so 1st of March 2020 to 28th of June 2022?
So I wasn't aware of the specifics of the modelling, but some of the outputs from that modelling I recall being discussed at meetings such as Quint.
Was any equivalent modelling done in Scotland as far as you were aware?
I'm not aware. I wasn't involved in any modelling.
That document can come down now, thank you. It has been suggested by some that the focus of IPC measures in healthcare settings was primarily on healthcare workers, such as through testing healthcare workers and universal masking, as opposed to means of preventing spread between patients. Do you agree with that?
I don't wholly agree with that, because I recall being involved or involving listening to discussions in relation to hospital capacity and bed spacing in particular, and how important that was. Concerns at times being raised about the ability to be able to adequately space beds because of volume of people, and to maintain that over time. As people began to look at various solutions for increasing capacity, one of the very strong things which I remember being pushed back was narrowing the bed spacing between people, for the very reason of the possibility of spread between people.
You've mentioned ventilation a number of times this morning. As the evidence about modes of COVID-19 transmission changed, did you ask for or receive any advice or briefings from the UK IPC cell or any other group about the impact of ventilation or access to clean air?
I don't recall having any briefing from the IPC cell in relation to that.
How about RHI?
I wouldn't be able to answer that with confidence.
Do you recall there being a discussion or any advice from anyone on the impact of ventilation and access to clean air on nosocomial infections, specifically related to patients?
I couldn't answer that question with confidence. I think It may have come up during advisory group meetings, but I couldn't say with confidence that was the case.
Do you think that...
Certainly,
Sorry.
could I qualify that by certainly say there was an awareness that ventilation was an important issue in that respect.
Given that you were aware that it was an important issue, do you think that you should have asked for work to be done on ventilation, access to clean air in the context of either nosocomial infections affecting patients or affecting healthcare workers?
I think it's a reasonable activity to have undertaken to try to establish the effectiveness of ventilation, particularly in areas where there were concerns about the ventilation, if those were arising. Again, I have to say that I wasn't directly involved in these conversations because I didn't oversee any of the infection prevention and control procedures or policy.
Do you think that ventilation and its role in the prevention of nosocomial infections was given sufficient attention in Scotland?
I remember it being a very, very live topic and one that ministers in particular were very interested in. I think it was given a great deal of attention and I remember the Chief Nursing Officer spending a great deal of time in relation to it.
My lady, that brings me to the end of a topic. Would that be a
Certainly.
convenient moment?
I shall return at 1:45.